massive medical mystery that affects millions of people but is so often completely misunderstood. We're talking about the cough that simply never, ever stops. Now, if you've ever had a cold, you know a cough is super annoying for a few days. But imagine that cough lingering for months or even years. Imagine it completely disrupting your sleep, your social life, and honestly, your sanity. So today, using the latest clinical statement from the British Thoracic Society, we're going to look at the hidden science behind chronic cough and discover exactly why the reflex that is supposed to protect us sometimes goes completely rogue. Okay, let's dive into this because this is where we kind of have to flip everything you thought you knew right on its head. For decades, both doctors and patients have operated under a very basic, seemingly obvious assumption. If you're coughing, well, there must be something wrong with your lungs or your throat, right? But what if that core assumption is actually pointing us in the totally wrong direction? What if your unstoppable cough isn't really a respiratory issue at all? To understand this massive paradigm shift, we first need to define what exactly we're dealing with. So, in the medical world, a chronic cough is defined strictly as a cough lasting more than 8 weeks. And let's be real, 8 weeks is a incredibly long time to be coughing day in and day out. What's absolutely maddening for these patients is that they go to the doctor, they get the chest x-rays, they get the scans, they do the lung function tests, and time after time, the results come back perfectly normal. You're sitting there exhausted, coughing nonstop, and the tests are literally telling you that you're perfectly healthy. Honestly, it can make a person feel like they're losing their mind. And hey, if you think this is just some rare edge case phenomenon, think again. The community prevalence of chronic cough could be as high as 10%. That is literally 1 in 10 people. Yet despite being so incredibly common, a massive portion of these folks just suffer in complete silence. They stop going to the doctor because they're tired of being told nothing's wrong, and instead they spend an absolute fortune self-medicating with over-the-counter cough syrups that, frankly, the evidence shows do very little to actually help. The stakes of this medical mystery are incredibly real. This is not just a minor annoyance. The hidden human cost here is staggering. Just look at these impacts. We're talking about profound, bone-deep exhaustion, physical chest pain from the sheer force of coughing, dizziness, and even syncope, which is feigning right in the middle of a coughing fit. It causes urinary incontinence, severe anxiety, and deep social embarrassment. People stop going out to restaurants. They totally isolate themselves. The British Thoracic Society actually notes that the impact on someone's quality of life is comparable to severe respiratory diseases like COPD. Section 1. Why old treatments fail. So you're probably wondering, why has medicine struggled so much to fix this? Well, this brilliantly illustrates the crux of the problem. Since the late 1970s, the standard of care has been something called the Anatomical Diagnostic Protocol. It basically assumed chronic cough was caused by a familiar triad: asthma, upper airway or sinus issues, and acid reflux. The strategy was essentially a process of elimination, blindly throwing treatments at these 3 conditions to see what sticks. The reality? 30 to 40% of patients do not get better with this approach. We've literally been using an outdated detective method that leaves a huge portion of people without any relief whatsoever. A perfect example of this flawed approach is what we can call the PPI paradox. Because acid reflux was part of that old triad we just talked about, doctors would frequently prescribe strong acid reflux medications, proton pump inhibitors, or PPIs, to chronic cough patients. And get this, they did this even if the patient had absolutely no heartburn. The latest data shows this is usually completely ineffective, blindly treating possible causes without objective evidence of medications they never actually needed in the first place. Section 2. The rogue reflex, a paradigm shift. Now, what's really interesting here is if the problem isn't always asthma or silent acid reflux, what is it? If we look at the neurophysiology, it takes us away from the lungs entirely and straight into the nervous system. Those vagus nerve fibers are carrying signals from your airways right up into your brainstem and central nervous system. Modern medicine has finally realized that in many chronic cough patients, the issue isn't in the lung tissue at all. It's a neuropathic disorder. The sensory nerves themselves have become hyperactive. This is what we now call cough hypersensitivity syndrome. The best way to truly grasp cough hypersensitivity syndrome is through a simple metaphor. Think of a broken smoke alarm. Imagine a smoke alarm that's so incredibly sensitive, it goes off not just for a raging fire, but when you light a little scented candle, or even when you just turn on the stove. That's exactly what's happening in these patients' nervous systems. Trivial things that absolutely shouldn't cause a cough, like talking on the phone, laughing at a joke, a sudden change in temperature,
or just smelling someone's perfume trigger an overwhelming, uncontrollable urge to cough.
And this isn't just some fringe theory either. It is now recognized by the top experts in the field. As the British Thoracic Society clearly puts it, in many patients, the primary disorder is a hypersensitivity of sensory nerves. This changes the game completely. It moves the target of our treatment away from just trying to suppress inflammation in the throat and onto calming the misfiring nerves themselves. Section 3. Targeting treatable traits.
So, how do we actually treat a misfiring nervous system alongside other potential triggers? We look at a multidimensional approach. Instead of slapping one broad label on a patient, doctors are now encouraged to identify specific therapeutic targets, or what they call traits, for that unique individual. Does the patient smoke? Are they on specific blood pressure medications like ACE inhibitors? Is there evidence of airway disease? Or is it primarily that cough hypersensitivity we just talked about? By identifying the exact trait, we can finally apply the exact right tool for the job.
Let's see how this builds into an actual functional treatment plan. Notice how hyper-specific this is compared to that old guessing game method. If the trait is the use of an ACE inhibitor medication, well, the treatment is simply to stop that medication. If it's airway eosinophilia, which is a specific type of inflammation, we trial inhaled corticosteroids. For acid reflux, we now only trial those PPI medications if the patient actually has objective heartburn symptoms. No more guessing. And crucially, if the trait is cough hypersensitivity, the treatment approach shifts entirely to things like speech therapy or neuromodulating medications. But how do we know for sure which trait a patient actually has? Simple. We use objective biomarkers. Instead of guessing, doctors can now look for concrete, measurable evidence. They can measure exhaled nitric oxide, or FeNO, and blood eosinophil counts to definitively prove there's airway inflammation before they even think about prescribing steroids. They use sputum cultures for infections and rely on the objective presence of heartburn before handing out stomach acid meds. This is the absolute heart of precision medicine, guys. Measure first, treat second. Section 4. The path to relief.
Okay, knowing the science is super fascinating, but how does this actually play out in the doctor's office? Well, it starts with a highly logical primary care pathway. Step 1 is the basic assessment, getting that chest x-ray, doing spirometry for lung function, and checking those blood and breath biomarkers we literally just mentioned to rule out anything serious. Step 2 is immediately stopping obvious aggravants. So if you smoke or take ACE inhibitors, those have to stop. Step 3 is using the objective data from Step 1 to identify and treat those specific targeted traits. It's systematic and it makes sure no stone is left unturned.
But of course, there are clear boundaries here. The guidelines are very specific about when a patient needs to be escalated to secondary care, meaning sent to a specialist. If you've gone through all the targeted treatments and you're still coughing, if the diagnosis is just completely unclear, or if there are red flags like coughing up blood or unexplained weight loss, it's absolutely time for a specialist. The whole goal here is to stop the endless, repetitive cycle of throwing basic treatments at the wall when a patient really needs higher-level investigation. So, the crucial point is this. Even if your cough falls into that tricky hypersensitivity category, there is tremendous hope out there. Because it is a neuropathic issue, we can actually retrain the brain and the nerves. Cough control therapy, which is delivered by speech and language therapists, is incredibly effective at helping patients actively suppress that urge to cough. And for those who need a little more help, specialized neuromodulating medications, drugs that physically calm the nerves, are showing great promise in clinical trials at finally quieting down that rogue reflex. And that leaves us with a totally new way to look at our own health. For anyone who has spent months or even years frustrated by clear x-rays and failed cough syrups, a simple shift in perspective might actually be the ultimate cure. Maybe the question you should be asking your doctor isn't what's making me cough, but rather, why is my nervous system overreacting? It's a powerful paradigm shift that paves the way for precise, effective relief. Thanks so much for joining us on this explainer, and remember to always keep asking the right questions.